afternoon, everyone. It's an honor and privilege for us on behalf of ISBMT to welcome everyone for the 18th Patient Support Group meeting. This meeting has completed 18 months, and that's a remarkable milestone for ISBMT, and a lot of effort has been put to put this group together um, under Dr. Revati Raj's leadership. Today, what we are going to discuss is a topic which is very important for perhaps the parents of children, and that is um, BMT for leukemias in children. And we will first start with the speaker, who is Dr. Satya Prakash Yadav. He is director of the Pediatric Hemato-Oncology Division at the Medanta Cancer Institute, Gurugram, and is one of the senior most pediatric oncologists in the country. I request Dr. Yadav to deliver his talk.
Thank you, Dr. Naveen, for the kind introduction. And I thank all the organizers from ISBMT for giving me this opportunity to share today's talk with you all. And so the topic given to me is bone marrow transplant for children with leukemia. And this is a patient support group meeting. So parents are attending this, and I think all the people involved in the support in the care of children with leukemia, like our nurses and other support staff, are also logged in, and few clinicians are there, both senior and junior. So I'll start with my disclosures. So I have nothing to declare. What we will discuss is there are four types of leukemia in children: acute lymphoblastic leukemia, which is the commonest, acute myeloid leukemia, which is the second commonest, and then chronic myeloid leukemia, which is very rare, like almost 1% of children get this kind of leukemia, and juvenile myelomonocytic leukemia, which is even rarer. So these four we will cover in this talk. And as acute lymphoblastic leukemia is the commonest, it will take majority of my time. My talk will be focused on that. And then AML would be the next focus point. So to start with acute lymphoblastic leukemia, as most of the people in this group and those who are listening to me, they know that this is the commonest type of childhood cancer. So if there are 100 children who get cancer, nearly one-third are diagnosed with leukemia. They have blood cancer. Leuke means white, and leukemia means the cancer of white cells. So leukemia is white blood cell cancer, and this is one-third of all cancers in children. And out of them, nearly 80% are acute lymphatic leukemia, ALL. So majority of childhood leukemia is acute lymphoblastic leukemia. 20% are acute myeloid leukemia. So the ratio is 1:4 or 1:5. So each patient of AML who's diagnosed, there are four diagnosed with acute lymphatic leukemia. Now the survival rates of this particular cancer have improved dramatically in the last 30, 40 years. And Western countries are reporting 90% plus survival rates for acute lymphoblastic leukemia. But it was not always like this. Way back in 1950s and 60s, this was a uniformly fatal disease. No one survived this cancer. And at that time, the scientists started working on treatments, and they discovered few chemotherapy medicines like 6-mercaptopurine, 6-MP, which many patients commonly take these days, and tablet methotrexate. And they discovered vincristine. They tried these chemotherapy alone, and nothing happened. Then someone thought that let's combine them together, give these 3, 4 medicines together in the same patient in the first 1 month and see what happens. And they found that majority of patients, more than 95%, achieved remission with 3 or 4 drugs given together. So combination therapy works for leukemia treatment. But what they found was that most patients still relapsed, and they relapsed in the brain. The leukemia somehow hides in the brain, and these medicines, 6-MP, methotrexate, they never reach the brain or vincristine. And they're not able to kill the leukemia hiding in the brain, although they can clear the leukemia from everywhere else. And this led to the further thought process. Pinkel, who was one of the doctors in Boston, Dana-Farber Children's Hospital, he advised that we should give them CNS prophylaxis. We should give them radiation to the children, to the brain, so that the leukemia dies and the leukemia doesn't hide in the brain and doesn't come back. And this improved the outcomes to around 40%. And then radiation was noted to have a lot of side effects. So later on, intrathecal chemotherapy started, it replaced it. So nowadays, we give an injection in the lumbar spine of chemotherapy, which goes into the brain and the spine, and it prevents the relapse of leukemia in the brain. Then still, majority of patients were still relapsing. Only 30 to 40% could be cured. And that was the time when the doctors and scientists thought that maybe longer treatment would benefit. So the concept of maintenance therapy came. That means you have got the child in remission. Now keep on giving chemotherapy for 2 to 3 years so that they maintain that remission. And at some point, their disease disappears. So initially, they were treating for 3 years, all children, and males, they had higher risk of relapse. They were treated for 3 years, and females were treated for 2 years. And later on, with the modern protocols, most children are treated for 2 years with chemotherapy, and they get all right. So that's taken care of majority of patients. But not all patients behave in the similar way. So cooperative groups started, and multiple cities or countries, they started treating patients on a uniform protocol and analyzing the outcomes. And in those protocols, they did the risk stratification. That means they try to divide patients into low risk, who respond very well to treatment, intermediate risk, who don't respond very well but still do well, and then high risk, who tend to relapse more often. And there is another entity called very high risk, who cannot be cured with chemotherapy. They need bone marrow transplant. So this risk stratification was based on certain factors like how you respond to steroids in the first week of therapy, and minimal residual disease, that how quickly you clear your disease and it gets into remission. That's the most important thing. So that's the these things help the doctors to give proper treatment to the patient and improve the outcomes further. But the patients who were relapsing, what to do with them? So as you see, these are the children's oncology group survival curves. In 50s and 60s, hardly anyone survived. But as in the recent survival, if you go towards 2000, early 2000, now it's 80% plus. And the recent survival curves are reported as 90% plus. So this was the status in India. In way back in 2010, I had written this letter to editor where I looked at all the outcomes across India, and we found that the overall survival rates were 60 to 70% and event-free survival of 50 to 56%. So around 50% of children were getting cured in India across various centers by 2010. So which was much better than what it was before, but still a lot more can be done for children in India. And if we look at relapse is the biggest problem, that children tend to relapse. And then after relapse, there are not many treatments. This paper is from 1977, 50 years back, almost 50 years back. At that time, relapse patients who were not responding to chemo, they were offered a new treatment. At that time, it was brand new treatment called bone marrow transplant from a brother or sister, allogeneic bone marrow transplant. And they expected these patients that no one would survive. But by this treatment, by bone marrow transplant, 18% patients survived long term, more than 5 years. And this proved that 1 in 5 patients could be cured with bone marrow transplant, even if they are not responding to chemotherapy. And this brought the concept of immunotherapy. That means a new immune system which can target the cancer, can clear the cancer, and you can be cured of cancer. And that's why bone marrow transplant has become a major treatment for patients who are not responding very well to treatment or who have relapsed after the frontline therapy. So for them, this is the treatment. And who did this? Sir E. Don Thomas. Sir Don Thomas is a pioneer who started doing transplants in Seattle way back in 60s and 70s. And he developed this treatment for leukemia and various disorders. So he got Nobel Prize in Medicine in 1990 for his establishment of bone marrow transplant as a treatment for a lot of disorders and mainly for leukemia. Now in India, when I trained way back in 2002 to 2005, I came back and started practicing as a consultant. So I found that in India, there was not many pediatric bone marrow transplant specialists. It was mainly adult physicians who were looking after children and doing their transplants. So we decided that we will do a capacity building for pediatric bone marrow transplant in India with mentorship, training, and international collaboration. So over a period of 13 years, from 2005 to 2018, we trained nearly 68 doctors in bone marrow transplant. And these doctors started working across the country. And with their help, they treated around 800 children and with a survival rate of 70%. This was reported at European Bone Marrow Transplant meeting in 2018. So, which was a big improvement that pediatric transplants started happening, and even for leukemia, they started happening. And the number of transplant centers were just 10 in 2005, and they increased to more than 100 now. So the transplant field has grown in India, and haplotransplant, which were not happening before, they started happening. More than 600 haplotransplants had been done by 2018. So these things helped the growth of this field in India, and now bone marrow transplant is easily available across India for children suffering from blood cancer. These are our trainees who started working in various parts of the country and helped establish BMT units there. Now this it looks even bigger because all the other centers they have also trained a lot of people, and entire India is almost covered except northeast and some parts of Odisha and Jharkhand where we don't have a lot of BMT units. But rest most of the country is covered with people who can do transplants for children. So with these refinements, like proper risk stratification, you looking for minimal residual disease, that how fast that leukemia is clearing. Those who are slow responders, we offer them bone marrow transplant. Those who respond well, we don't do transplant. Those who relapse, we offer them transplant. So these things help refine, and this is the paper we published recently from our center. So overall survival of 88%, which is almost close to the Western literature of more than 90% survival. We are approaching that in India also. And if you look at the event-free survival, it's 80%, which is quite good. So in the last 30, 40 years in India, the outcomes for acute lymphatic leukemia for children have improved, and they are reaching in certain centers to almost Western levels. And the improvements are continuing across India. Now, bone marrow transplant, when we want to offer it to children with cancer or leukemia, a donor is required. Usually, it's a matched sibling donor, a brother or sister who's a fully matched. We do HLA typing of the patient and the donor. And if they both express the same HLA type, that means their bone marrow is similar. And then we can use that donor to donate bone marrow, and it's done in the operation theater. The donor is taken to the operation theater, given anesthesia, and from the back part of the hip bone, we put needle and suck out the bone marrow. This is I am doing bone marrow collection from a donor for a patient, and anesthetist is sitting there, and the donor is in a prone position. It takes 1 to 2 hours to collect the bone marrow, and then it's given fresh to the patient who is undergoing transplant. Before putting the new bone marrow, we give strong chemotherapy to finish the old bone marrow and old leukemia. Then we put the new bone marrow, and this bone marrow brings a new immune system. It starts working in about 2 to 3 weeks' time, and this new bone marrow brings new immune system which kills the cancer and cures it, as Sir Don Thomas had shown way back in 1977. Then peripheral blood stem cell collection. So not all patients, donors are comfortable giving a bone marrow. They don't want a needle to be put in the bone. So these days with modern technique, we can collect the stem cells, bone marrow stem cells from the blood. What we do is that we give some injections to the donor called GCSF injections, which stimulate the bone marrow to make a lot of bone marrow cells and they come in circulation. And then we connect the donor to a machine, an apheresis machine, like how we collect platelets. Similarly, the machine, from one side, the blood goes into the machine, the other side, it comes back into the donor. And in 3 to 4 hours, it collects the bone marrow stem cells in a bag. And this can be given to the patient fresh. So this is less painful, no anesthesia required. So most of the donors these days prefer peripheral blood stem cell collection rather than bone marrow collection directly from the bone under anesthesia. Cord blood stem cells, so they are something which we use less often, but all families where a child is suffering from leukemia, and if the mother is expecting the next baby in the coming months, so they should store the cord blood stem cells in a cord blood bag, and those cord blood stem cells can be used for transplant of their child with leukemia if required. So the cord blood stem cells, when the baby is delivered, the placenta, the cord blood has a lot of stem cells. They can be collected in a bag and stored in liquid nitrogen at minus 180 degrees centigrade for many years. And when we need, we can use this. So if you see, these are frozen at minus 180 degrees, and you cannot put your hand in this. It will give frostbite. So wear your special gloves, and you use a magnetic rod to take out the cord blood unit from this bag, the canister, and then you thaw it. You have to unfreeze it. These are frozen, so you put it in a temperature controlled regulator where they are warmed slowly, and then they become like blood, and then it can be used for transplant. So bone marrow transplants, how many have been done in India? So as I told you that in the first 20 years, from 1986 to 2005, as per the Indian Society of Bone Marrow Transplant registry data, 10 centers were doing transplant, and total 1600 transplants were done till 2005. Total 1600. And after 2005, there was a revolution. A lot of transplants started happening. And now there are more than 100 centers. And every year we are doing 2,500 transplants. This year we have reported, I think, more than 3,000 transplants in the last year, as per the data. And more than 20,000 transplants have been performed in India. And I think the number has gone to 30,000 as per the latest into 2025. But India needs to do far more, around 50,000 transplants every year. So it is still less. And bone marrow, more BMT physicians and beds are needed. At Medanta, we have done more than 700 transplants so far. So when you want to do transplant for acute lymphoblastic leukemia, we need to know what is the best preparation. Preparation is the conditioning. So before we put the new bone marrow, we need to finish the old bone marrow and try to kill the leukemia to maximum. So there are two options. One is total body irradiation and other is chemotherapy. So total body irradiation has a lot of long-term side effects. So the scientists decided to do a trial to compare head-to-head whether radiation is better or chemotherapy is better to prepare for transplant. So if you see this was known as forum trial, where the children were in two arms. One was given radiation, other was given just chemotherapy, and then the bone marrow cells were put in. And if you see, the relapses in the blue are more with chemotherapy arm. With radiation, the relapses were almost 50% less. And the survival was also better for children who got radiation as a preparation for transplant. So now, as per this study forum trial, if you are doing a matched related donor transplant or matched unrelated donor transplant, you have a full matched donor, then radiation is the best option as a preparation for transplant. But when you don't have a matched donor available, because Indian families are shrinking and we don't have siblings available, and quite a number of times you don't have a sibling available as a donor, then we look for unrelated donor in the unrelated donor registries. But unfortunately, India, we don't have many registries and our ethnic mix is too much. So we need a lot more donors than the Western world. In Western world, there are more than 5 million donors, Caucasians, who want to donate their bone marrow. So if a white person needs a bone marrow transplant and he doesn't have a matched related donor, a sibling, then easily there is a 90% chance that we'll find a fully matched unrelated donor in the donor registries. But for an Indian origin person, it's difficult to find fully matched unrelated donor in the registries. So for all those patients, previously no transplants were being offered, and they were like stuck that once you don't have a full matched donor, nothing can be done. So we started doing bone marrow transplants from half matched donors. So that is, you parents are usually half matched. So parent to child transplants we started at our center. And for leukemia, we published this and showed that it is safe and effective. In our study, we showed that nearly 70% patients survived after transplant, and 64%, that means two-thirds of the patients were cured of leukemia. So these were the patients who had no donor available, no matched donor available. So we could do the transplant, and now haplotransplant or half-matched transplants are routine transplants across India, available in most centers. So no child should die without a transplant if they need a transplant, because donors are available these days from the family. Mother or father can be a donor. Even half-matched siblings can be donor. Your first cousins or your brothers, sisters, or mother, father can be donors. Anything better than bone marrow transplant? Yes. In acute lymphatic leukemia, if you see this girl, this is her name is Emily Whitehead. So Emily Whitehead had B cell acute lymphatic leukemia, and she was treated when she was 2 or 3 years old, and she responded. Then she relapsed. After relapse, she got chemo and a transplant. Then she stayed well for some time, then relapsed again. Again, she got chemo and a second transplant, and she unfortunately relapsed again after the second bone marrow transplant. Then the doctor said, now no treatment is available. We cannot cure this leukemia, and nothing much can be done. Father of the child, Emily Whitehead, he said, any new trial, any new treatment people are trying, please connect me to those people. So Dr. Steve Grubb, who was the physician at Children's Hospital Philadelphia in US, where this child was being treated, he said there is Professor Carl June, who has developed a new treatment and he can help you. So they went to Professor Carl June. He said, yes, I have a treatment. I have a treatment which works in mice very well, and we need to start human trials. I don't have funding. Money is not there for this trial. So the family arranged, they did the crowdfunding, some money was arranged, and the trial could start. Emily Whitehead was the first patient who got this new treatment. So, what was this new treatment? So the immune cells of the patient, Emily Whitehead, the T lymphocytes, they were taken out from her body. T lymphocytes normally fight infections and they can fight cancer also. So these T lymphocytes were taken out. In the lab, they were genetically modified with the help of a virus, and their DNA was coded to express a new receptor against CD19 protein. And the cancer cells had CD19 protein. So once they made this new T cells called CAR T cells, chimeric antigen receptor T cells. So these CAR T cells were put back into Emily Whitehead, and then they started killing the leukemia. But she developed very high fever, and it was continuous fever for next 24 hours. After that, she needed ICU stay. Her blood pressure dropped, and she had breathing difficulty. She needed ventilator, and it looked like she won't make it. Then, by the chance, the doctor who was treating her, Dr. Steve Grubb, his daughter had a rheumatological problem, and they were giving her a treatment called tocilizumab, which is an antibody against inflammation. It can block the inflammation. So they checked the inflammatory chemicals in the body of Emily Whitehead, interleukin 6, which was very high. And then the doctors gave her an injection to block this inflammation, this antibody called tocilizumab, and she responded very well. Her fever went away, and next day, ventilator could be removed. And to this day, she's free of cancer more than 10 years later. She's now almost 19 years old, and there is no cancer. After a week, they checked the cancer. There was no cancer detectable. And so many years later, there is no cancer. And these cells are still present inside her. So one of the companies, Novartis, has started making these cells commercially, and this is being sold as a treatment. So these are called living drugs. CAR T cell therapy is a drug, but it's a living drug. These are cells which can cure cancer. And fortunately, in India also now CAR T cell is available, and a lot of patients have been treated, but it is yet to be approved for children less than 15 years of age. So I'm hoping that in this year, this would be approved for children less than 15 years of age, so that more and more children can get this new treatment and be cured. So at our center, we had a couple of children who had relapsed after bone marrow transplant. And to them, we offered CAR T cell therapy, and they could be cured with CAR T cell therapy. So it's a big hope for the patients in whom transplant has failed, or they have relapsed after transplant, or they are not responding and unable to reach transplant. For them, CAR T cell therapy is an option. Now, what is the future of transplants? So, the whole idea is to reduce the toxicity. So, we want to give less toxic treatment so that the long term side effects can be reduced. And we want that no child should die during transplant because of complications. We want, if the cancer cannot be finished, we want to tame it and control it to very low levels with medicines. So, that's another approach. Chemotherapy free treatments are coming up for leukemia in adults. Ph positive leukemia is treated with dasatinib and Blincyto. These are targeted therapies, and these adults have been cured of Philadelphia positive ALL without chemotherapy. So this may be the future for a lot of children. Infants, they can't tolerate strong chemotherapy, and they have very strong leukemia. For them also, CAR T cell therapy is a big news. And then NGS based treatments and a lot of new things. CAR T cell, right now we have to prepare it outside, and it leads to a lot of problems, but we can prepare it inside the body in future, and that would be wonderful. Just few slides about acute myeloid leukemia. It's a challenging disease to treat, 50 to 60% survival. Again, we need to stratify the patient who are high risk, low risk. Usually high risk patients need a transplant, or those who relapse need a transplant. So this was a paper we had published many years back, where we showed that treating AML is challenging in India because of a lot of infections, a lot of complications. So if a center can treat AML successfully, they are ready for doing a lot of transplants. And we published our center's data, which showed that with transplants, outcomes can be improved in AML. This is the result of haplotransplants from US, where they showed 0% mortality. No one died during transplant. So haplotransplants is another option where in AML patients, it can be a safe bet if they don't have a matched donor available. Then coming to TCR alpha beta, that's another approach of doing transplants. When you have a half-matched donor, the donor cells can cause a reaction, graft versus host disease. So we can remove the cells which cause this graft versus host disease called alpha beta T cells by a special technique, immunomagnetic column, and these cells can be given and patients can be cured. And results of this TCR alpha beta depleted transplants are excellent, nearly 70% survival. So that's another option for the patients who don't have a full match donor available. CML is highly curable with tablets. And this was a Time magazine cover many years back, way back in 1998, where magic bullets, Gleevec is the medicine which can cure it. And patients just take this tablet, they don't need a transplant, majority of the patients. But those who go into blast crisis or the disease starts increasing despite the medications, they are offered transplant. So like this child who had a relapse in the brain, blast crisis, we transplanted and did well. JMML is very rare. Like each transplant center maybe get one or two patients in a year. And this again is difficult disease. We had published long time back that in India it's a challenging disease. Relapse is the main problem. 50% of children relapse after treatment. But nowadays, with proper molecular typing, we can know which patients need transplant. If a child has CBL mutation, they don't need a transplant. We can watch and wait, and they do well. Those who have other mutations, they usually need a transplant, except NRAS. they can again be observed if they are clinically well for many years. We don't offer them transplant upfront. Most other patients need transplant. Decitabine and azacitidine are the good agents to control the disease, to reduce, shrink the spleen before transplant, and that has improved the outcomes. I'll finish here. Thank everyone and happy to take questions. Long-term side effects is one thing which we need to monitor these children for. Nearly 40% of children 10 years after transplant have some problem. So all patients need to be monitored regularly after transplant. Every 5 yearly, they should go for checkup. Must. That's our team. Thank you. Happy to take questions.
Thank you, Dr. Yadav, for a very comprehensive and a very simple way of uh, delivering this lecture. Really suited for not only for patients and parents, but even for physicians like us.
Thank
Thank
you,
you
sir.
so much. Um, we have maybe a minute or two for some questions. Are there any questions in the chat box, uh, Roshni?
No, sir. No, sir.
Right. So maybe I'll ask you one question, Dr. Yadav. So, children with leukemia, the parents already have one child with leukemia, and then we ask them to, take the other child if available and do their HLA typing. And suppose if it's a match, full match or half match, and take the normal child for collection. Um, what would be the right way for those donors? Do you think bone marrow harvest should be done, which used to be done many years back, and now everyone starts doing peripheral blood collection? What is your opinion on
Yeah.
you know?
So great question. One is that ethical things. So that means the donor who he really wants to donate or not. These are small children. They can't make a choice. An adult can always refuse or agree. Most donors usually agree in a family. They want to help, but a lot of counseling is required of these children. Mentally, they have to be prepared. They might be scared when we do this procedure. So before that, they need to be talked, and a psychologist can be involved so that they are not scared when they do this donation. And peripheral blood stem cell is easy to collect. And most families, we give both the options, they prefer that. And these days, more than 90% of transplants, we are using peripheral blood stem cells. And the outcomes are quite good with peripheral blood stem cells. It's well tolerated and outcomes are good. So, bone marrow is a rarer option, but sometimes some families agree for bone marrow collection as well, and we collect bone marrow. But as you say, rightly said that the comfort of peripheral blood the donors wanted, and we do that. So thank you.
No, the only concern remains the growth factors that we give to the donor. And some parents obviously will be worried whether
Yeah.
the growth factors can have some late effects after
So
5-10 years on the donor. What is
there,
your opinion on
there
it?
is a lot of data because transplants have happening since 1977, and peripheral blood stem cell collection also started way back in 90s. So now we have nearly 30-40 years of experience with GCSF and peripheral blood stem cell mobilization. So there are not many reports of anyone having developing any leukemia, the donor developing any problems because of GCSF. So at present, it looks like it is very safe, and we can use GCSF to collect the stem cells. So there are no worries in my mind at all. Thank you.
Sure. Maybe one more question I will ask you before we hand over to the panel discussion. Uh, children are going to live for long if they get cured. Not like adults where, maybe their life gets curtailed because of many other complications. So so when we counsel patients for transplant in children, at least their parents, what is the sort of 10-year survival that you put in for leukemia, acute leukemias, which is a survival which makes them functional to the society? Because some of them develop complications, and
Yes.
they live a life which becomes very difficult for the whole family. So how do you counsel those?
So, as we, what most of the published literature shows 5 year survival. So, at 5 years, those who are MRD negative, their disease is under good control before transplant, nearly 70% are cured of leukemia. That's what is reported. But if you have active leukemia, then the survival rates are just 20% or 30% if MRD is positive. But long-term follow-up, the data which is coming from West as it's lacking from India, that shows that nearly 3 to 4 out of those 10 children, like 30% of the children, will have some issues. Like chronic GVHD can still be troublesome for many years. So that has to be watched out for, and that can cause a lot of disability like joint stiffness, walking problems, very thick skin, appetite problems, weight loss, urine problems, when they're passing urine, it hurts them, having irregular periods, and other those sort of things are there. So long-term side effects need to be monitored in the children after bone marrow transplant. That's very, very important. And if you see another 5 to 10% people may have late mortality because of a second cancer, because all these treatments can cause a cancer as well. So the risk of developing cancer may be somewhere like 1 to 2%, that out of 100 children, 1 or 2 may get a second cancer later on because of the treatments we give. And similarly, if they have severe chronic GVHD affecting lungs, that can lead to mortality, and other severe chronic activation of donor cells can cause problems. But fortunately, we have better treatments, better drugs. We can control chronic GVHD, but prevention is best. If we don't get GVHD or chronic GVHD, that would be the best for children and will give them the best possible quality of life. Thank you.
Thank you, Dr. Yadav. Thank you so much. I think we will now go on with the next part of this webinar, which is a panel discussion. And I have the great opportunity to introduce the moderator of this session, Dr. Silky Jain. She's a senior pediatric hemato-oncologist and bone marrow transplant expert at the ESIC Medical College and Hospital, Faridabad. Over to you, Dr. Jain.
Thank you so much, sir, for that kind introduction. And it's my pleasure to moderate this panel discussion on the occasion of International Childhood Cancer Day. So I would start by introducing my esteemed panelists today. So we have with us today Dr. Srinivas Chilkuli. We are very grateful to him as he joined today because Dr. Laskar couldn't join because of some urgent commitment he had. Dr. Srinivas is professor and senior consultant in radiation oncology at Apollo Proton Cancer Center, Chennai. Then we also have Ms. Poonam Thorat. She is nursing officer at TMC Actrec in the BMT unit. Then we have the pleasure of having Dr. Rajat Bhattacharya with us. Sir is senior consultant in pediatric hemonc and BMT at Apollo Cancer Center, Kolkata. Then it's a special occasion, so we have with us Mrs. Jaya Thakkar, who is a proud mother of a lymphoma survivor, Sujal Thakkar, and she is also a yoga instructor. So welcome all the panelists. And I would like to share my slides, my screen, please. Yeah. So is it visible?
Yes, ma'am.
Yeah, so we can
All
see.
right. So, yeah. So I would like to start with Dr. Rajat. So, sir, as it is very clear from Dr. Yadav's talk that not every child with acute leukemia needs BMT, only some of them do. But whenever we mention this term BMT to a parent, to a parent of a child who is suffering with leukemia, they often get very anxious and worried. So, how do we explain to them that what are the pros and cons of BMT versus chemotherapy in a particular patient? And what is the main deciding factor for choosing BMT over chemotherapy in certain patients with leukemia?
Thanks, Elki. I'll try to make it a bit more simpler. So when Satya has already discussed about the BMT, the conditioning, etc. in leukemia. So when we are saying bone marrow transplantation, the main idea is that doing a bone marrow transplantation is to transfer a different immune system to the child, so that you kill the existing leukemia cells from the child's bone marrow, and also you're transferring somebody else's immune system, and hopefully this immune system will continue to kill the patient's leukemia cells, what we call graft versus leukemia effect. So when we choose bone marrow transplant, of course, is much more intensive, and Satya has discussed about so much of long, intense, and the toxicities, immediate and long term. So we would not advise a bone marrow transplant unless it is necessary. And when it is necessary, the simple thing is that when we think that chemotherapy is not going to be able to cure the leukemia, and the indications are quite different in acute lymphoblastic leukemia, myeloid leukemia, JMML. Most of the JMML need BMT for cure. So when we think conventional chemotherapy will not be able to cure this leukemia, then we are advising a bone marrow transplantation. Of course, this is based on the existing literature, our personal experience, and the ability to do a transplant, as Satya has already said. The important thing about the pros and cons of BMT, bone marrow transplant, of course, has got immediate and long-term side effects, and the cost is an issue. It's much more intensive than a chemotherapy. There are something called transplant mortality, which can be about 10 to 15% till you may die during the transplant. So these are the things we have to keep in mind. The other complications of the graft versus host disease, which Satya has already said, can be a chronic problem. So the child may be cured of leukemia, but then suffering from a chronic GVHD. So efforts are being made and things are improving to prevent the chronic GVHD. And even after doing a transplant, about 20-25% will still relapse. So despite of doing everything, they may have a relapse. So it's a very fine balance about when we advise BMT is absolutely necessary, and mainly keeping in mind that chemotherapy may not be able to cure this leukemia. Now, I must say to you, from my early days of BMT in early 2000s, bone marrow transplant is not how it used to be in those days. It's become much safer. We have learned a lot from the pre-existing experience and the toxicities and things. So using a what I could reduce toxicity chemotherapy regimen as an induction, the toxicities have become less and the techniques have improved and the supportive care has improved. So it was not that very high risk procedure, what used to be said 20-25 years ago. Things have improved. So the goalposts and the lines are definitely changing. We're having less intensive chemotherapy, immunotherapy is coming, and transplant is getting safer. So all I would say, whatever we say today may change in 1 year time, who needs a chemotherapy and who is going to need the BMT, based on all these things. So
True,
it's
sir.
a very
So
moving line.
correct, sir. So
Yeah, thank you.
the assessment of the disease is a dynamic process, and that's how we get to know that which child will need BMT or not. And if BMT leads to higher survival, is likely to lead to higher survival, then we offer that. And of course, BMT is a life savior in certain patients, which the transplant physician will let the parents know. So moving on to the next question. My slide is not moving somehow.
Ma'am, in the bottom, you can see a arrow. Please click on
Okay,
that.
all right, yeah. Thank you. So, Dr. Srinivas, so as we know that there are mainly two kinds of acute leukemia in children. The more common type that is called ALL, acute lymphoblastic leukemia, and the less common one that is AML or acute myeloblastic leukemia. So in which one of the two is radiation considered a part of the standard conditioning regime for BMT in children? And what is the name given to the technique which is used? What is it called?
Well, radiation specifically, the total body radiation, which Dr. Yadav already mentioned, is most commonly used in children with acute lymphoblastic leukemia, which is the more common variety who are undergoing bone marrow transplantation. So, in In ALL, of course, not all patients require bone marrow transplantation, and TBI is used only as a conditioning regimen, as a preparatory treatment before a bone marrow transplantation is done. And usually it is done for patients who have a relapsed ALL going for transplantation, or very high risk, sometimes ALL in first remission itself, patients are considered for bone marrow transplantation. Patients who could be having persistent disease or persistent measurable residual disease, which we call as MRD, also could be one of those who could be subjected to transplant, as being mentioned by the previous speakers. Patients who have CNS involvement could be one of the indications wherein a bone marrow transplantation could be done. So overall, in ALL, whenever a bone marrow transplantation is done, the options are between using only chemotherapy and a total body radiation like approach. And Dr. Yadav showed in his presentation that the forum trial, which showed that with the use of radiation or TBI conditioning regimen, the outcomes were better. The death or mortality related to acute lymphoid leukemia was lower, and therefore I think TBI remains one of the commonly used standards of treatment for patients of acute lymphoblastic leukemia whenever a bone marrow transplantation is considered.
Thank you.
AML is TBI is typically not used routinely, and therefore very exceptional situations only I would say TBI can be done in AML patients for leukemia. Majority of them do not require, so only ALL would be the right patient population for this particular treatment.
Okay. Thank you so much. Yeah. So in ALL, we do consider using TBI rather than AML. So Mrs. Jaya Thakkar, so it's an absolute pleasure to have you with us today. And I think our audience must be waiting to hear from you your first-hand experience of dealing with a difficult disease and how you dealt with it. So, can you please briefly describe about how you dealt with the breaking of news of a difficult disease in your own child, and what were the feelings you had at that time, and what was the most challenging issue that came up in taking him up for bone marrow transplant?
Good afternoon, everyone. So, Sujal had a pre-existing blood disorders since childhood. We did have a hint that, at some point Sujal might face this challenge in future, but we never really expected that, cancer would come knocking at the door. So we were definitely shaken as any parent would. Everything came down crashing. So yeah, we did have challenges like, about finances and many other things we were thinking at that point of time. And since we were in Malaysia, we had to bring Sujal to India, and we had our complete faith in Dr. Revati and her team, like literally the blind faith, and of course, God was very kind to us. So the other challenges were donor, COVID, lockdown, moving countries. These were the challenges at that point of time. But Sujal, my son, has been a real fighter, I should say. So with his strength, that is what kept us going with him.
Thank you. So, Dr. Rajat, so there is a child who presents on day plus 30 post transplant, a child with AML who presents with a mild skin rash on the trunk and on the palms. So, would you be worried about this patient, about this presentation? And there's another patient who is completely doing fine on day plus 60 post transplant. So, which of the which of the two situations is more worrisome for a transplant physician? And you please explain our audience what is meant by graft versus leukemia effect and why is it important?
Thank you, Silky. I think you're referring the first rash most likely to be something what we call a graft versus host disease. Of course, a child post BMT will be coming to us for follow-up about once or twice a week, and we look for any complications. So at day plus 30, a child with AML comes with just a skin rash. I'll, of course, go through the history examination and things and think what this could be. It could be a drug, could be infection, but the most important thing we have to look forward is graft versus host disease. So that means the donor cells are attacking patients, child's normal skin cells. And this is because, remember, this is the immune system of the donor is different from the child. So this may be a full match donor, full HLA matched, but there will be some, two individual person is different. The immune systems are different. So the donor's T cells, T lymphocytes, are probably attacking patients' normal skin cells, the skin cells causing a skin rash, because majority of what we call antigen presenting cells, the cells are in the skin. So mild skin rash, so this is probably a GVHD. Of course, I'll think of other options. And but this is day plus 30. A mild GVHD is okay. It's actually good to have a little bit of graft versus host disease, because we think that also means that the donor's T cells are probably having cells which will be attacking against leukemia. So that's called a graft versus leukemia. And graft versus host disease and graft versus leukemia effect usually go a little bit hand in hand. So more GVHD, probably you expect more graft versus leukemia. So day plus 30, if it's just localized to the skin and not affecting the other important organs, that the intestine and the liver, I would be actually quite okay with it. A day plus 60, no GVHD, would I be worried? Well, I would personally not worry too much. As long as the GVHD is not getting too severe, I'm okay. Absence of GVHD, does it mean increased relapse risk? Answer is actually probably no. But yes, if you have a severe GVHD, your relapse risk is less. So day plus 60, would I be really worried? I probably would not worry too much. That's all I would say.
Okay. Thank you, sir. So the point what we wanted to highlight with this is that mild GVHD in leukemia patients is not bad for the patient. So okay, so Dr. Srinivas, as we know that no therapy is devoid, absolutely devoid of all the side effects. So would you like to highlight the short-term and long-term side effects of total body irradiation that a patient can have?
Yeah, so as I mentioned previously, that radiation does improve outcomes when used appropriately, but it also comes with some amount of side effects, and side effects are usually cumulative. Remember, these children are receiving a lot of chemotherapy drugs, medications, supportive medications, etc. So these are, I would say, cumulative, although radiation would be contributing some significantly to the list of toxicity, which I'm going to mention, which could be short-term side effects, which can happen during or shortly after the treatment, which include something like nausea and vomiting, fatigue, hair loss, ulcers in the mouth, mucositis, diarrhea. Of course, the blood counts drop. There are some skin reactions, some pigmentation. Typically, these improve with the modern supportive care with good antiemetics, etc., etc. There are some long-term side effects as well, which are, I would say, some of them are more concerning side effects, and not every child develops these. So these are, I would say, rarer by use of modern techniques. But growth delay is something which is not very uncommon in younger children. Hormonal disturbances such as thyroid dysfunction, is also not very uncommon. Delayed puberty, fertility issues, cataracts are quite common because of the involvement of the lens and need early cataract replacement, reduced lung function, reduced liver function. These are fortunately rare complications, and reduced renal function as well. All three are fortunately rare complications, but these are sometimes can be attributed to the radiation therapy, especially to the older techniques. And of course, as Dr. Yadav mentioned, second cancers as well. Many years later, after 10, 15 years, 20 years, there are large burden of medical and other problems in these children beyond 10 years, and therefore it is very important to use techniques which can reduce these burden of side effects, including modern techniques of radiation therapy.
Yeah. So, thank you so much, Dr. Srinivas, for that comprehensive description of the toxicities. So, as Sir Dr. Srinivas have highlighted that there can be skin toxicities, there can be mucositis as a transient side effect of TBI, and there comes the role of nursing care. So, Mrs. Poonam, I would like to ask you. Can you please highlight that how would you take care of these children who are undergoing TBI in the BMT unit, and especially in the terms of skin and mouth care? And is there anything that we can do to prevent these toxicities or dampen the intensity of toxicity?
Thank you, ma'am. Good evening, ma'am. Thank you for the question. Thank you, ISBMT, for this opportunity as a panelist. Yes, for children undergoing TBI, skin and mouth care are very important due to the increase the risk of dryness and irritation and infection. As a nurse, we need to explain the procedure to the child and parents in a simple way or reassuring way. Maintain the calm and comfortable environment, provide monitor vital signs, hydration well, and ensure adequate nutrition and fluid intake. Observe for side effects such as fatigue, dryness, nausea, and discomfort. Prior shifting to the patient for the TBI, provide light breakfast, administer pre-medication, that is granisetron or dexamethasone, or hydrate patient well. The skin care is very sensitive during and after TBI, so careful care is very essential. Use mild and fragrance-free soap for the bathing. Pat the skin, dry gently but do not rub. Apply prescribed emollient and moisturizer lotions to prevent the dryness. That is Vaseline, petroleum jelly, or Vaseline lotion. Avoid hot water, heating pads, or ice packs on the skin. Prevent friction by using soft and loose clothing and bedding. Do not apply perfumes, powder, and harsh lotions on the skin to avoid the irritation. Assess the skin daily for redness, dryness, and irritation. Uh, the mouth care also very important because TBI can cause mucositis. Assess the oral cavity every shift for the redness, ulcer, and pain. Encourage gentle mouth rinsing with salt and water or prescribed solutions. Use soft toothbrush. Avoid alcohol-based mouthwashes. Keeps lips moisturized with lip balms or petroleum jelly. Provide plenty of fluids. Keep the mouth moist. Provide small and frequent meals. Avoid spicy, hot, and acidic foods that can irritate the mouth. Provide pain relief as prescribed by the physician for the patient's discomfort, mouth discomfort. Watch for the signs of infection. Thank you.
Thank you so much, Mrs. Poonam. You prepared your answer really well, and I really appreciate it. So, uh, as we all know that BMT is kind of a very unpredictable procedure, and some of the patients may tolerate it quite well, but an occasional patient may land in severe complications. So, Mrs. Jaya, would you like to describe very briefly about the complications that Sujal went through post-transplant, and how did you and the whole family dealt with this situation?
Yeah, so Sujal did have severe GVHD, graft versus host disease, He also had BK virus, wherein he had a urinary tract hemorrhage, and he was bleeding heavily at that point of time. Then later, of course, with extreme low platelet count, and he also had osteonecrosis in his knees. Later, post transplant of 3 months later, he was, after a year almost, yeah. So that is where he was diagnosed of osteonecrosis in his knees, where the blood supply completely stopped in his both his knees. And the complications and was that, arranging the donors for blood and platelets. Sujal literally needed duration of his treatment. He needed more than 60 units of blood and platelets. And arranging donors at peak COVID was no joke at all. So that was the biggest challenge that we faced at that point of time. And Dr. Revati had even introduced us to an NGO, and they were really, really helpful. And it was. And Sujal, as I said before, he had that fighting spirit. So that is how, as family, we could just stand together and face it all. And yeah, and your next question is, did you ever feel like giving up? But giving up was not an option at all for us.
Great. So, Dr. Srinivas, you explained about the complications that can happen or the side effects of with the conventional radiation techniques. So, is there any way that we can reduce these complications with newer techniques? And are these techniques accessible in India?
Yeah, so there
Especially, it
are
is important for children who have a long life ahead of them.
absolutely, absolutely. So there are, I mean, I mentioned several of those complications, and those complications have been attributed to the TBI. The traditional forms of TBI, which are older techniques, which essentially delivered uniform doses to both the bone marrow as well as to the rest of the body, including the heart, lungs, kidneys, gonads, etc., etc. So uh, there are essentially newer ways to give the same total body radiation, wherein we call that as organ sparing TBI. We could use a regular open fields or intensity modulated radiation therapy, which is available in a lot of centers across the country. Now can deliver these doses to the bone marrow while sparing less doses or giving less doses to lungs and kidneys and eye lenses, etc. Essentially, we regulate the dose to these structures so that the complications could be limited. There are other ways to spare the organs as well, which is called a total marrow or total marrow lymphoid irradiation. We call that as TMI or TMLI. Essentially, it does the same job what a TBI does, but essentially the radiation is focused only to the bone marrow and to the sanctuary sites, the lymphatic regions and the sanctuary sites. So we spare the heart, the lungs, the mucosal structures, including the esophagus and the bowel. Uh, Kidneys, gonads can also be spared. So, and oral mucosa, especially because patients have a lot of oral mucositis, so that can also be spared significantly by use of this newer technique called total marrow or total marrow lymphoid irradiation. The early data at least suggests, and when I say early data, there are now 10-year experiences available, which shows that these techniques lead to reduced toxicities across some of these domains which I've mentioned. Related to the question related to the accessibility, see, TBI is available almost in many big centers across the country, including government and private centers. But the organ sparing and the intensity modulated TBI are available at limited locations, but they are still available in, I would say, large cities. But total marrow lymphoid irradiation, on the other hand, is a specialized procedure. It is a time intensive, labor intensive procedure, and therefore it is available only in few cities across the country. It obviously depends on the center having newer machines, newer planning systems, as well as the treating team which has experience of doing these advanced techniques. So Access is improving, I must say, across the country, but the latest, the TMI, TMLI is available only in limited centers.
Yeah. Thank you so much, Dr. Srinivas. So, Dr. Rajat, so often it is seen that parents worry too much about the disease coming back in the patients of leukemia. And if it really becomes true, then it might be the worst nightmare of their life. So, is there anything that can be done preemptively to keep the disease under control, to keep the disease in remission? In other words, to prevent the relapse of leukemia.
Yeah, okay. So I think the biggest problem with transplant in leukemia is still the relapse of the disease. So that has to be understood, that the relapse of the disease is still the main threat. So we do whatever necessary. So one thing for sure is that before going to transplant, they have to be in remission, especially for ALL. For AML also, if they're in deeper remission, transplant will work better. And post-transplant, there are strategies for acute myeloid leukemia. Now there are medications which can give preemptively, so to try and prevent the disease relapse. For ALL, again, one of the things we do is we try to induce some graft versus host disease, if possible, in both ALL and AMLs. And that may be very short, what we call GVHD prophylaxis. So medication will suppress the immune system to prevent GVHD. In leukemia post-transplant, if they're not having any GVHD by say 2 months, 3 months, we will just taper off the immunosuppression. Donor lymphocyte infusion means giving the donors T lymphocytes, which includes T lymphocyte, which causes what we call graft versus leukemia effect. Yes, we can sometimes give a small amount of lymphocytes to induce the graft versus leukemia effect. Preemptively to cause it, it's a little risky, I would think, to give it, because you cannot control it completely. Sometimes the GVHD sets in, GVHD may be out of hand. But yeah, there are many strategies we are now taking. And it's important to take that, because still after BMT, the most risk is the relapse of the leukemia. And if it relapses with BMT, very difficult to salvage. Yeah.
That's
Thank
true.
you.
So there are techniques, there is hope out there. That is what we can say. And I think it is the meticulous monitoring with which the transplant physician monitors the disease, those important decisions are taken. So, Miss Poonam, now the everything said and done, it's a big moment for the family once the patient, the child has undergone transplant in the BMT unit and is now getting discharged from the BMT unit. But it's very important for them to understand the discharge advice, because they need to understand that the medications would go on. And so, what are the important points that you highlight or explain to the patient while they are getting discharged from the BMT unit?
Yes, ma'am. Counseling at the discharge from the BMT unit of the patients and relatives are very important before going home. Objective of the counseling, that is ensure safety at home, prevent infection, promote recovery and reduce anxiety of the patients and family. First is the infection prevention. In that, environmental hygiene is very important. Clean the patient's bed and chair, table or other frequently touching things or surfaces with the antiseptic solution, that is Dettol, twice daily. Floor cleaning, also we need to clean floor twice in a day with the detergent powder and antiseptic solution, followed by toilet cleaning with the Harpic or Domex before and after each use. Personal hygiene also is very important. Brush the teeth with twice daily with soft bristle toothbrush. Do not use tongue cleaners or dental floss. Take daily bath below the waist with using mild soap and water, and rest of the body with the soap and water and clean water and gentle drying with the towel. Hair wash is allowed, but avoid wetting of the Hickman catheter exit sites. Linen and clothing change the patient's clothes daily, change the linen, that is bed sheet, pillow cover daily, and blanket once in a week. Wash the patient's clothes with the detergent powder and again soak in the antiseptic solution for 20 to 15 minutes and again squeeze and dry in the sunlight. Medication compliances: take prescribed medicine at correct time, correct dose as per the discharge chart. Do not skip the doses. Do not take other medicines without doctor advice. On OPD days, do not take any medicines before collecting blood samples. Diet and nutrition: eat well cooked food, avoid outside uncovered food, avoid raw fruits and salads. Follow the phase of diet which is given on discharge time. Maintain good hydration and consult dietitian on each OPD day. Follow up and visit. Patient may have light breakfast and tea before going to daycare. Hickman catheter flushing and dressing is to be done twice in a week, that is Tuesday and Friday at daycare with the prior appointment. The patient and relative should reach daycare on time. Carry flushing and dressing materials. After blood sample collection, patient take breakfast and take the medicine and before going to the OPD. After OPD consultation, check for any changes in medication. Then emergency guidelines or warning signs: monitor body temperature with the digital thermometer twice in a daily. If temperature is 99, recheck again after 15 minutes. If persists same, then contact with the BMT doctors. Do not consult any outside doctors unless advised by the BMT team. Report immediately if any you have noticed fever, bleeding, cough, cold, any rash, loose stools, vomiting, or any new and unusual symptoms. Immediately contact to the BMT doctors or directly come to on the second floor or BMT. Keep hospital contact numbers handy all the times. And general instruction also important. Do salt and water gargles 3 times in a day. Avoid direct sunlight. Wear cap, mask, goggles, and use an umbrella. Wear full sleeves shirts, front buttons to facilitate Hickman catheter care. Do not shave. Cut the hairs. Nail cutting if platelet count is low. Avoid visitors and children under 6 years until immunosuppressive medicine is stopped. Avoid crowded and public areas, that is malls, theaters, railway station and D-marts. Do not swim in public pools. Caregiver must wear N95 mask when going outside. Avoid exposure of fresh fruits and gardens. Avoid contact with pet animals. Wash patient utensils with soap and water. Boil once daily and store in clean and dry area. Wash hands frequently, especially before touching Hickman catheter, before and after meals, after using the toilet whenever necessary. Use aquaguard water boiled for 15 to 20 minutes and store in clean container. Yeah, water. Thank you.
Thank you so much, Mrs. Poonam, for highlighting those very, very important points that patients should keep in mind after discharge. So, we have reached the last question of the panel discussion. Uh, uh, Yes. So, Mrs. Jaya, we all heard your story, your inspiring story, and the ordeal that you went through, the courage with which you faced it, and ultimately came out of it victorious. And we are very glad that Sujal is not only alive but doing well. And it's, I think, an inspiring story for many of the similar patients and parents out there who are listening to us. So, would you like to give some one message that you would like to give to them?
Yes.
What would it be?
The only message would be have your 100% faith in your doctor, because there'll be many people around you that would come forward and give you unwanted advice, take this opinion, that opinion. No, just very strongly, I would say this: have complete faith in your doctor. When you trust your doctor, things just, work out miraculously. And as parents, I would say be a strong team towards your child, be compassionate, keep pouring love, and unshakable faith in God is what works. And keep praying, because miracles become your lifestyle when you pray continuously. That's
Absolutely.
all. Yes. Thank you. Thank you so much for having me.
So thank you so much to all the panelists. And
Thank
with
you.
that, we close the discussion.
Silky,
And
there was only one question. Somebody asked how many cycles of BMT is necessary. It's actually just one cycle. BMT is
okay.
you just need once.
Yeah. So I hand over to Dr.
Sorry, Karen.
Naveen sir and Dr. Revati ma'am to close the session.
So,
Ma'am, Dr.
yeah, thank you, Silky, and all of our four lovely panelists. And to Dr. Satya Yadav for the session. It's really been a great moment for us at ISBMT, because we had the president of ISBMT, Dr. Naveen Khatri, joining us today, and the president of our PHO chapter, Dr. Satya Yadav, delivering the lecture, and it has all been possible because of generous sponsorship from our sponsors, Genova, Cipla, and Novartis. Thank you. But I just want to end by saying 15th February every year we celebrate International Childhood Cancer Day. This year, the last 3 years, the campaign has been from challenge to change. We want to increase the cure rates for childhood cancer from 30% in our country to 60% overall and beyond. Most of the centers are seeing upwards of 80%, but we want to bring the overall standards up to 60%. And I want to dedicate today's session to all the mothers like Jaya, and all of the wonderful nurses like Poonam who care for these children and really make all of their struggles a lot easier for the difficult times. And it's wonderful to see these children grow, become young adults, and do all the things that they ever wanted to do, and make their families proud of them. Thank you very much.
Thank you so much,
Thank
ma'am.
you, everybody. Thank you.